Welcome to our last video for the sections of the DSM for the semester. We have basically two categories that we're looking at for today. We're looking at the paraphilic disorders, and then we're looking at kind of a couple other last things to wrap up the DSM. So our paraphilic disorders is probably the area that most students are least comfortable talking about. Because this is when we're looking at things that are related to sexual interest, sexual desire, sexual behaviors. So a paraphilia will denote any intense sexual interest other than sexual interest in common behaviors with consenting adults. So we're looking at something that is a disorder that is a paraphilia is currently causing distress or impairment to the individual, or when the satisfaction for the individual has harm or risk of harm to other people. So it could be either one of those two. It may or may not be disturbing to the actual individual. Note that having a paraphilia is not sufficient to having a disorder. So there's a difference between the two. So a good example of this is someone might have a fetish for feet. They love feet. Feet really turn them on. That's fine. That's not a disorder. That's a paraphilia. But it's not a disorder unless it's causing impairment to someone or distress to someone. So if it does not bother that person or their partner, great. Carry on, do what you want. However, if it's causing distress or impairment to that person or maybe to the partner of that person, which is then causing a problem in the relationship, then it might be enough for the disorder part. There's two groupings for this. So one is looking at the activity preference, so behaviors that are distorted or not socially acceptable. We're looking at the voyeuristic, the exhibitionist, things like that, or categories that involve pain or suffering. Typically you see this with the pairing of sexual masochism or sexual sadism, or possibly a pair of people, one with each of those. Our second group is going to be the target preference. So it's when the preference is either at a person or a group of people that do not want that attention, or it's targeted more to an item or a thing. So we'll take a look at some of those. Note that it's not uncommon that a person might have more than one of those paraphilias. They may or may not be closely related. Not really important, just make sure you note them if they are more than one of them are there. Most common assessments are going to look at the strength of the paraphilic sexual behavior compared to their non-paraphilic behaviors. So how much are they behaving appropriately in other parts of their life? This is something that also can be specified in full remission. So it is something that a person can get treatment for, potentially not get treatment for, but usually they will, and then it will not be a problem anymore. Especially I would say if the problem is more in the relationships because of that disorder. So take note of that. A couple of the ones that you're going to see more commonly, and again, we're not going to go through all of these because there's quite a few of them, and the patterns might be fairly similar as far as the way we're looking at the diagnoses. So with the exhibitionist disorder, we're going to look at sexual arousal from exposure of one's genitals to an unsuspecting person. So we're thinking kind of along the lines of flashers here, someone who might go into a public place and expose himself, and they're arousing, getting pleasure from that. The individual will have acted on these urges, or they cause significant clinical impairment to that person. Note that there's some specifiers depending on the age of the non-consenting people. So if they prefer to do this in front of children versus adults. Usually adult males will report first becoming aware of this interest or this desire to do this during adolescence. And you tend to see this the most in adult males. Can be difficult to distinguish from age-appropriate exploration. So one of the things that we want to be aware of is that if we're looking at children, we want to rule out just them exploring, learning about themselves, their bodies, how sexual relationships work. This is not what we're looking at for this category. Do note that this could be and often is comorbid with other diagnoses. Some fairly common ones include bipolar, depressive, anxiety, substance use disorders, and I would say especially that antisocial personality disorder, because remember, we're going back to that I just don't care about the effect on other people with that category. Can become in full remission, and we don't really know how often this happens. This is not something that people are going to often want treatment for. Again, this is going to be something that might happen more often for treatment when we're looking at people who have been court-ordered because they've been arrested. When we're looking at sexual masochism and sexual sadism disorders, I put them together because they're very closely related, but they're two sides of the two opposite sides. Masochism is looking at related to having an arousal because of the act of being humiliated, being bound, being beaten, something in that category. Whereas when we're looking at sadism, we're looking at arousal coming from causing the suffering to the other people. Keep in mind that, again, people can have these desires and behaviors as long as it's consenting and not causing that clinically significant distress or impairment. That's okay. That's what they want to do. But as soon as we are either having that clinically significant distress or impairment, or it's happening with a non-consenting person, that's when it's now diagnosable, no longer okay in our society. Note that there tends to be a lot of pornography in both of these areas. And there also tends to be other paraphilic disorders that you'll see with these. So I think there's some pretty popular literature going around right now on these categories. If you want to take a look at that, feel free. Movies as well. Paraphilic disorder is going to be one of the ones that we see fairly often in treatment because it involves children. So when we're looking at sexual urges involving a child or children, often multiple children, and the person has either acted on these or they've caused distress to themselves, so that they know that they are attracted to the child but they don't want to be. That's when we're going to be diagnosing this. And we want to make sure that there's a fairly good age gap between the two. So we're not looking at a 16-year-old who likes a 14-year-old. We're looking at least 5 years difference between the individuals. And the individual with the diagnosis has to be at least 16 years old. So keep in mind, again, we're looking for a significant age gap between the two. And it's often going to be more than that 5 years. We might see the 16-year-old engaging in behaviors with a 5-year-old child. So that's more what we're looking at. There tends to be a lot of pornography associated with this category as well. And again, a lot of association and interaction between pedophilia and that antisocial personality disorder where that person just does not care about the effect on other people. You will see that a lot of the times the adult males will report that they were sexually abused as children. So sometimes when I see this, I almost think of it more as not necessarily in the same category as PTSD, but a way of trying to deal with what has happened to them and way of trying to interact with the behaviors that they were taught. So something that's more, we can see why it was caused and we can see what we can try to do to change that behavior. And a lot of times there is going to be that interpersonal difficulty, that distress, that not wanting to engage in behaviors with children. So when I see things like that, I tend to think of it as more of a treatment-oriented, not they just don't care kind of thing, like the antisocial personality disorder. Transvestic disorder, we're going to be looking at arousal from cross-dressing that causes distress or impairment. Lots of different specifiers with this. almost always males engaged in dressing as females. And when you think about that, that kind of makes sense. If a female dresses as a male, they're wearing jeans and a t-shirt, which is very common for a female to do as well. So it's not as distinct as far as the types of clothing that might be worn for females. So the first signs of this might be in childhood, and it might start with the interest in one particular item of women's clothing. So one of the things that we want to make sure we look at is that we're looking at the arousal from cross-dressing. We're not looking at cross-dressers. We're not looking at males who feel more comfortable in women's clothing and maybe want to live out their way with their life with a female identity. That's not what we're looking at here. We're looking more at that arousal piece. And it might interfere or detract from heterosexual relationships. That's also something that you're going to note and might be a major component of the treatment with the individuals. That kind of wraps up our paraphilia category. There's kind of a smattering of leftover things in the DSM for basically when we can't really tell what's going on. So our other mental disorders, kind of at the very end, page 707, it's going to look at 4 different categories. We're going to look at other specified mental disorder due to another medical condition. So there's a physical reason for the mental health disorder. An unspecified mental disorder due to another medical condition. So again, physical reason for a mental health disorder, but we don't know exactly what that is. Maybe we don't even know what category to put it in. Other specified mental disorder and unspecified mental disorder. So again, when we don't often have enough information to diagnose with any of the other things we've talked about all semester, we can use one of these at least to get started with. This might be kind of a residual category, might apply to presentations in which symptoms characteristic of a mental disorder that causes clinically significant distress or impairment, they exist, but they don't meet the full criteria for another disorder. If this is because of a medical condition, make sure to list that medical condition and then follow that with the specified or unspecified code depending on which one you're using. We might also have the medication-induced movement disorders or other adverse effects of medication. So that's starting at page 709. These are included because we're looking at the management of medication and we're wanting to be able to allow for the differential diagnosis of mental disorders. So you're going to list this depending on the medical issue and the type of movement. So a good example is a medication-induced acute dystonia, where dystonia is that abnormal and prolonged contraction of the muscles, it might be the eyes or the limbs. So someone stiffens up and they can't relax their arms. It's not an intentional movement. It's something that they have no ability to relax. So that's an example of how we might code a medical issue and a type of movement into a medication-induced movement disorder. We might also have what we call V codes. So they're conditions that might be a focus of clinical attention, but they're not necessarily a mental health issue, if that makes sense. So they're listing of conditions and problems that might be the focus of clinical attention and might affect the diagnosis, prognosis, and treatment. Again, we call them the V codes. So it might be relational problems, maybe a divorce, it might be abuse or neglect for an adult or a child. It might be educational or occupational issues, housing or economic issues, problems related to the social environment. So we used to call these also conditions that we would list on Access 4. So we're looking at things like homelessness or abuse or loss of a job. So all of those things might be the focus of clinical attention, but you're not going to diagnose a person with homelessness. So that's kind of the way to think of these. And they will still have some specific coding numbers and V codes that you can use along with them. And that is the end of our DSM-5. So we are done covering at least the basics of the DSM. Again, you should have read through these enough to kind of know where to start looking when you see a client with some diagnostic criteria. So you're looking at, okay, this person is coming into me with this, and this symptom. This is where in the DSM I should start looking to see if I can find an appropriate diagnosis. A lot of this is going to become a lot easier the more you get into practice. So the more you're actually seeing these diagnoses and working with supervisors to make sure you understand them, the easier it's going to be to at least understand certain categories. You're never going to work with all of the different diagnoses. You're probably going to become part of a work environment where you're seeing a handful of them fairly often and learning how to treat those very well. So you want to be able to know at least what those criteria are, and if someone comes in with something different, know to where to look for to find out what that diagnosis might be. So that is our DSM, and as always, questions can be in the discussion board.